Okay guys, I'm really excited about this new change in the way that we're going to do exams. One of the things that I hope to bring to the table is a renewed focus with the SFMA. I've been reading and re-going through the FMS and the SFMA and the whole idea behind a very good checklist of movement assessment, and I believe that ties in very nicely with what we're doing. Of course, a reminder, I really need you to be doing lumbar scans and cervical scans. That goes for new employees, no question. In fact, I'd love for you to send me filled out forms of them, proving to me, showing to me that you've done maybe 10 of them before the end of the year. Just 10 of them. 10 lumbar and 10 cervical. And if you can do that, or even just 10 total, your skill set, your value, your marketability, your knowledge, your pattern recognition will be amplified. I can promise you that. So here's my encouragement to you is use the lumbar scan to implement what I'm about to show you with the 4-box system, is what we're going to be calling it, of methods of thinking diagnostically. With AI coming down the pipe, I'm concerned that we retain our ability to properly diagnose. And so in doing so, if we practice the fundamentals, if we practice the basics, we will be great diagnosticians. If you want to work in a practice that only does workers' comp and they're going to lift that box from the floor to the top shelf, you're not in the right place. You need to go find that. If you're going to work at a place where we're only looking at joints, an orthopedic practice, a physician-owned orthopedic practice, where you're going to look at post-surgical cases, don't bother. You don't need to be a detective. You don't need to be a great diagnostician. But on the other hand, if you want to work with athletes that keep hurting themselves, or you want to work with post-motor vehicle accidents, if you want to work with chronic pain, if you want to work with our population of people that come to us as the musculoskeletal experts and have done so for 10 years, you've got to get on board with this. So I'm going to present it to you in a way that is hopefully clear, since what we did in the dry needling collective was very 30,000 foot view, but now we're going to get boots on the ground and look at it. Let me start by saying that the basis for this is helping you leave no stone unturned. That's what checklists do. And if you think you can do it without a checklist, you can't. If you think that you can approach our exam the same way that you do when you were only given 15 minutes to do it prior employment or in your clinicals, you can't. If you're going to try to approach treating people in our clinical setting by doing a quick, selective tissue tension exam, which is always my recommendation if somebody comes to you at the end of church or you see them in the supermarket and they want to know if they have lateral epicondylitis, you can do a selective tissue tension exam and probably get a lot of information. But after you've done an excellent subjective with proper follow-up questions related to pain behavior, you've got the subjective in the bag. You've ruled out signs of serious pathology by asking proper questions related to the review of systems or systems review, and you've understood their medication and sort of their history. You can recognize history and demographic, both age and body type, and have all these things sitting on your back burner, knowing that that is going to influence what we're about to do. But after you've gotten that all in the bag, it's time to start the exam. You get your cervical and lumbar scan out of the way, but you're going to be putting on your thinking cap, because you're not a technician simply gathering information in the examination. You're going to be doing your evaluation while you're doing your examination. And I'll just say a word to the new employees. I strongly encouraged you to do the scans. I don't back down from that. I want you to continue to do that. But there will come a day when your brain is going to think faster to get to the root of the problem than it is now. Give it time. I would say 18 to 24 months before you're able to just pick out things, partly because you just haven't seen enough. You haven't had the experience. But I'll warn you as well that if you're going to go the next 18 to 24 months without using the things that I've shown you, I think you're going to be 5 years down the road before the organic nature of experience makes you into a great clinician. You can circumvent time. You can get into a time machine if you pay attention and you apply what I'm about to share with you now. So it's for you. It's an offering for you. Much of what we're going to do education-wise is going to be a request and an offer. But I would take my offer. Of course I would, because I like it. Now, let's talk a little bit about the 4 areas. The first one is an ICD-10 diagnosis that will probably come from the doctor. Now, you too will be adding your own ICD-10 diagnoses to the bottom right-hand corner of the exam sheet if you find something else to work on. We are a direct access state. If they come in for their left elbow, you can work on their right knee. And you should work on their right knee. That's how we operate. That also really denotes what's called selective tissue tension exam. So it will then be a tissue diagnosis. By and large, ICD-10 codes are tissue diagnoses, and those are very good because oftentimes when we have a torn or tendinosed or broken tissue, we then know that that is really what's at fault. That's what might need to be surgically repaired. That's what might need to be handled differently in terms of its stage of healing, as we've talked about in dosing and strategies to accelerate healing. So it's not unimportant to know the tissue that's at fault or the tissue that's injured. It's just not enough. We're also going to be looking at impairments. And for those of you that have hung around me a little while, you know that Nagy model of disablement that we were taught in school, it's a continuum, poorly named continuum called disablement model. I would love to hear it talked about in terms of ablement model, but we're trying to help people with disability. And a lot of times we circumvent disability by we circumvent impairments by looking straight towards their disability. And so when we treat people, yes, a tissue diagnosis is what's considered pathology. Then we move to an impairment, which we'll talk about what that is in case you don't know in a second. And then there's a functional limitation, and that may look at in terms of how the movements operate together. And then lastly, you might be dealing with what's called disability. If they can't do their sport or their work or their home activity, let's get them to do that activity that they can't do. I've seen it too many times in clinical practice where we jump to that, where we disregard the stage of healing and where we disregard the impairments, and we don't even look at regional interdependence or functional patterns. And so at the end of the day, it's really important to know that even though that continuum is poorly named, it is one framework we're thinking. I need to understand the pathology. What does it look like under microscope or MRI? Histologically, what does that look like? Secondly, what impairments exist? Thirdly, how does those impairments impact human movement? And lastly, how does that human movement deficit impact disability? But if you're going to point your target, point your aim at the tissue or the pain, you are going to be chasing the wrong thing most of the time. What you need to do is start by the impairments. If you can point your arrow, your focus, your energy at the impairment, you'll do so much better, I can promise you that. So the second way of thinking is thinking of things in terms of impairment. So we've got T, we've got I, and ultimately an impairment, as you well know, since you've been to school, is really less to do with, is it a torn meniscus? Torn meniscus isn't an impairment. Thigh pain isn't an impairment. A tight upper limb tension test isn't an impairment, right? But what's an impairment? An impairment is decreased in range of motion or increase, and whether that be osteokinematically with the bone that we can measure with a goniometer if we use that still, or a PIVM or an arthrokinematic range of motion, looking at joint play, which we're developing our hands. We've talked about that before. Ultimately, our hands are good scanners that will help us identify end feel. It will also help us identify when we're hitting R1 and R2. These are basic fundamental skills. Remember, we're going back to the fundamentals and looking then at arthrokinematics from what we do with our hands, and osteokinematics with what we do with our hands or what we observe with a goniometer will clue us into impairments. Impairments will also include strength, and that too needs to be bisected, much like range of motion. Strength gets bisected into what we are traditionally calling a metabolic weakness, which is measured with a dynamometer, and a make test, which is much, much safer, or using a break test to measure for neurologic fatiguing weakness, which then is a different type of weakness. It's a fatiguing weakness that, certainly metabolic demonstrates fatigue for us to know, but ultimately the reason we tie that word neurologic fatiguing weakness together is because we see that happening slightly differently, maybe not all that slightly differently, when we see a rapid decrease in the ability to hold a contraction, even when the tester is letting off of the force, and it's still, due to a factor of time, will break the muscle test. So those are great examples of impairments, and certainly we know that in PTA 101, PT 101, where we use our gonio to figure out what's going on. We do our manual muscle testing from Florence Kendall, and we understand then that those are a big part of what we do. Hopefully we have good hands that we can palpate both muscular facilitation and inhibition. Those would also be considered impairments. Now those impairments of muscular facilitation or inhibition, which bifurcates, right? What's the tone of the muscle? Too tight or not tight enough? What's the condition of the joint? Tight or loose? But what's the condition of the joint arthrokinematically and osteokinematically? You see all these bifurcations, right? What's going on with the muscle, metabolically and neurologically? Now, is there overlap? Yes, there's overlap with each one of these categories we're about to show you, and there's certainly overlap sometimes between metabolic and neurologic weakness. Sometimes, and most often, if there's arthrokinematic stiffness, there's going to be osteokinematic stiffness. And so those are all things that, as quickly and efficiently as we can get at recognizing patterns related to impairments, I think we're halfway home. The ICD-10 diagnosis came from the doctor or from your speculation based on what you find in your exam, but at the end, or maybe from imaging, but at the end of the day, if you don't understand what impairments are tied to that MRI or X-ray, if you're not understanding what impairments are tied to that tissue problem, I think you're going to miss the boat. So then we have to take a higher level thought. We've already done range of motion, which is on the exam form. We've done reflexes. We looked at tissue tension. We've looked at facilitated inhibited atrophied. We looked at PIVMs. We looked at gross range of motion of the cervical spine and extremities. And we've really accomplished looking at as many impairments as we can. But what are we going to do next? If we want to understand regional interdependence, you've got to be pulling out that SFMA, go back to that, look at the score sheet or the checklist, and you've got to be looking at people moving. You got to have them walk, you got to have them squat. If we can't do that, we won't see how compound movements influence the impairments, or the impairments influence the compound movements, and we'll just be missing things with our blinders on. In addition to that, we can look at impairments in the lumbar spine we should look at impairments in the lumbar spine if we have a lower extremity issue, and vice versa. We look at cervical issues when we have an upper extremity issue. And so at the end of the day, I'm going to stop saying the end of the day, but one of the things we've got to be confident in order to sleep well is that we're also looking at regional interdependence, RI. And I'm taking you through a continuum, but as I said, they could be interrelated. You might start with looking at an SFMA and then move to looking at impairments, and that will come up with your tissue diagnosis. But I would also be doing a selective tissue tension exam. We're not going to use this time for that, but if you don't know what a selective tissue tension exam is and how to apply it, I will go through that with you. I'll be happy to do that because I think it's an extremely useful tool. To dividing, again, bifurcating into either inert tissue or contractile tissue, and that makes you a great diagnostician. Otherwise, honestly, I don't think you should be in this profession. If you can't differentiate between a nerve and a muscle, or a joint and a muscle, or I'm not saying tendon and muscle, because that can be tricky to differentiate between those two. But we as diagnosticians, and I'm speaking to PTAs as well, because you're doing progress notes, you're not diagnosing, but you are most certainly assessing, which means you can figure out if what was seen in the exam has changed or improved, or if you might need to say to your PT, I wonder if this actually is tight hamstrings and not sciatica. All of those things are going to happen when we don't just go, knee pain, here are my 5 knee exercises. We cannot do that anymore, not at PhysioPoint. Now, the last thing, and this is new for me in my practice, is really understanding what Curtis calls the afferent nervous system and what Nate calls the afferent nervous system. We all know the difference between afferent and efferent, downgoing and upgoing. Upgoing neurologic symptoms that tell us, is it hot, is it cold, is it vibrating, is it sharp, is it dull, is it moving fast, is it moving slow? A lot of that information is coming from the Golgi tendon organs and the mechanoreceptors. And so this afferent nervous system is so crucial at telling your brain what your body's sensing down below so it can take the appropriate action. The efferent nervous system, as you know, is connected to motor control. But how in the world am I going to know if I should move faster or move slower if I'm not getting that feedback of telling me what baseline movement, distance, and agility is happening? And so those are all things that if we again, I kind of look at this afferent nervous system. I'm going to tell you, I went years without really paying too much attention to it. And I think, to say I did my clients a disservice is a true statement. Was it intentional? No. But you now can't unsee what you've just seen here with regards to ICD-10 or tissue diagnosis as it relates to impairments, which we've been beating that drum for years at PhysioPoint. Likewise, regional interdependence, looking above and below the joint, looking at spinal influence on an extremity, looking at how opposite sides can affect the other opposite side, looking at Vladimir Yanda's work, looking at upper cross, lower cross syndrome. All of these things help you think broader, but you can then also funnel that down when you know appropriately how to think about pattern recognition. I'm just giving you the 4 categories of pattern recognition. How you tie it all together is something that experienced clinicians will do. But again, that assessment that happens should really start during the exam to some degree or another. Let me give you an example. If you test somebody's hip extension on one side, after you've palpated their psoas major, and one of them was tighter than the other upon palpation, what is my natural hypothesis when I test the range of motion? Well, it's that the side that's tight is going to also be the side that's limited. We're always doing, knowingly or unknowingly, we should be doing some form of hypothesis testing, but when I then go test the contralateral limb from the tightness of the palpation study, and it's then moving better or worse, I can then either affirm what I thought, oh, that's great, what I was thinking came true, or I can go, that's different than I've noticed the last 30 times or 100 times I did that test, or for maybe some of us, 1,000 times. And when that happens, it then hits you in the face because it's so different than what you've seen before. And so you can maybe start to see why creating a method of thinking will make you a better PT, a better diagnostician, provide greater value, have more clients, get more reviews, have less cancellation rate. This is a business. We are trying to win, and this is your strategy for winning. Okay, now let's talk a little bit more about the nitty-gritty. When we look at upper limb tension test, which category does that go in? If I have a tight inflammation or adhesion of either the upper or lower limb tension, how do we think about that? Is that tissue? I would say yes, because it's an inert tissue. Nerves are not contractile. But does that point to an impairment? I think it will, because it will limit range of motion. In fact, we might need to correlate that with our range of motion testing, knowing that, in fact, the range of motion is less influenced by the tightness of the muscle or the joint, not the shortness, but the tightness of it, unless we're dealing with a true contracture. And so maybe then we decide, no, they just had tight biceps, not a positive upper limb tension, or no, they had tight hamstring, not a positive straight leg or slump test. Or in fact, yes, it was a positive. And ultimately then, if we land on that, we understood a tissue, we see what impairments that might be related to as they're running, or as they're reaching into the cupboard, or as they're reaching for the ATM card. But additionally, we got to consider the afferent, the regional interdependence thinking philosophy comes from us saying, I wonder how having a tight hip flexion or tight elbow extension influences his movement. And yes, you would then watch them walk. You would look at how they move when they reach, and certainly doing the SFMA will give you an indication of some of those things. Now, the other part of that though, and I'm just trying to see how sometimes certain findings fit into almost all categories. We also want to know, what would a positive slump test for inflammation do to the afferent nervous system? It would constantly be sending pain signals to the brain as it relates to some inflammation that chemically is irritating and probably mechanically is compressing nerve tissue. And we'll have to identify then too where that's located. Is it in the cauda equina? Is it above the cauda equina? Is it maybe being compressed or inflamed at the carpal tunnel? Those are all things that we can dive deeper into with breakouts, but we have to understand that the afferent nervous system is going to be a player here. The other area we can look at with afferent feedback loop is with trophic changes that would then denote chronicity, but it would also denote the high likelihood that there's a sensitization. What tool can you use to try to identify whether there's central sensitization? Well, the answer there is the app by David Butler, where you can identify their lateralization. Just because they don't score poorly, and by the way, 85% of 2.5 seconds or less is within normal limits, greater than 85%. But just because they score well on that doesn't mean there isn't components of afferent disruption or sensitization, particularly if they're painting dermatomes, particularly if there is a certain inability to sense movement. And so you do have to be paying attention to the afferent nervous system to get a complete picture of how that's going. And so one of the ways that you can really do that is when you're doing range of motion testing, let's just say range of motion of the neck or the back, you can ask them which one is tighter, which one feels tighter. When you're doing PIVM, ask them which one feels tighter. It's not just about pain, guys. It's can they sense when they're actually not moving as far? And I will hazard a guess that these chronic patients that may or may not have trophic changes, may or may not have obvious signs of central sensitization, are motor morons, not because they were born that way. We all know that type. Those motor morons are born with it. We're talking about acquired motor moronity, or whatever the word would be, right? They're not understanding how far they can move because their pain system has messed with their mechanoreceptors, which happens after traumatic injury and surgery every time. Their Golgi tendon organs have gotten messed up too due to their either chronic pain or possibly an acute pain. But when they don't know how far, is your knee straight? Is your knee straight? You know, we have this with total knees all the time. Oh yeah, it's straight. They're lacking 5 degrees. They just don't know. And that's why you are the musculoskeletal experts of Northwest Indiana. And you're going to then teach them how to move. But if you forget the afferent nervous system, you won't be doing things like lateralization training, mirror therapy, and visualization, or desensitization 3-to-5 protocol. If you don't know the 3-to-5 protocol, and that is new to you, you shouldn't let this video go by without making a note. Let me reach out to Nate and ask him what the 3-to-5 desensitization protocol is, and then I can share that with you. But if you understand, of course, that there's decreased range of motion in the elbow, you'll know then the arthrokinematics, the concave convex rule, what muscles to look at and to see if it actually is a contracture, and you'll do something to treat that impairment. Well, what happens when they can't understand if they're moving fully to the right or fully to the left, or what happens if they don't know if their knee is straight? Well, that's where you do need to consider the PAG effect. We've talked about that before, that if we are going to use mobilization, and I'm all for Freddie Kaltenborn's grades of mobilization, or was it Maitland? Sorry. Kaltenborn was the concave convex rule, and Maitland was the grades of mobilization. But you need to know that, backwards and forwards. This is out of school. This isn't board exam and forget this stuff. You've got to know it, you've got to apply it, understand it in terms of R1 and R2, and be ready to give an answer. When we ask you guys about inflammation and adhesion, there's always a little bit of a fumbling. There's no more time for fumbling, right? If we're going to do this well, we're going to do this right. Get it in your head and figure it out. And if you don't like it, you want to do something different, come to me and let's figure out what's even better than thinking about it through that lens. But the same would be in terms of grades of mobilization. You need to know that like you know where the gas pedal is. You just have to. And if you do, you'll become better for it. In addition to this train of thought, I really want you to focus on this technique, and if this is going to go on the back of your exam forms. So once you've gathered your information, flip it over and go through a differential diagnosis after you've gotten their subjective. So they give you their subjective. I woke up one morning and I had pins and needles down my leg. and I'm 35 years old and I'm a construction worker. What tissues could be involved? What ICD-10 diagnosis would you come up with? You can certainly go afferent, you can go impairment, you can go regional interdependence with your differential diagnosis. You can put them right into each box, but just put those little words at the top. Stenosis, disc herniation, regional interdependence might be tight hips that are influencing poor lumbar mechanics, whatever. It might be an impairment of poor TRA control, whatever. You can call it instability. I don't know which category instability goes. Maybe you'll find a fifth category, but put in your working diagnosis, your hypothesis into each of these boxes, and then cross them off as you eliminate those with good quality examination skills, which are hopefully happening alongside your evaluation skills. And then you'll get to use this. You might be flipping that paper, you might find yourself flipping that paper back and forth. I'm guessing you will, because you'll be harvesting information as a technician, putting it on the front side of that exam sheet, and then trying to discern how that influences these 4 categories of thinking about diagnosing. And then you'll have tools and hopefully you'll be using the right tool to treat the right category of examination. So I'm so stoked about this. I'm super excited about this being the key to unlocking high quality examinations. You've got a full hour to do this. There's no reason you ought not to do this. So I'm really going to strongly encourage you to try it out. We can refine this. This is a work in progress, but everybody's nice. Everybody loves you. And that's true of all clinics around for the most part, unless you're rude. Unless you start out as the doctor of physical therapy with highly skilled, highly knowledge, and of course you're super friendly and you're caring. So compassion is not normally an issue within our organization. Precision with exercise can sometimes be lacking, most certainly, and we all are not perfect, no question. But when it comes to the growth that you need to think about in terms of going back to the basics, much of this stuff you've heard, much of the stuff that I've went over today is stuff that's fundamental, okay? It's fundamental to what you've been taught. It's fundamental to very basic continuing education courses, and it's very important for you then to go back to the fundamentals. That's why Kobe Bryant was such a winner, is he went back to the basics. He didn't try to reinvent the wheel. And if we do want to get lost on nuances of all the fun stuff that we can go take a course on out in the world today, I'm fine with that. Bring that in. We'll look at it. We'll chew it up and we'll spit it out, or we'll chew it up and we'll bring it into our system, into our schema of how to think. But at the moment, some of you are not thinking, and some of you are not processing the information, and some of you don't even know how to dig for it. So my hope is that this prompts you to say, you know what? Being okay and being nice isn't good enough. What I need to do is figure out how to be the best possible diagnostician possible, so that I can then really surface some information, mine for some gold nuggets, and then I've got tools for those gold nuggets. I know about the 3 to 5 desensitization. I know about lateralization. I know about visualization. I've got red cord. I've been applying the PAG effect. I've been doing contract, relax, hold, relax stretching, because I've learned that in school, or one of the clinicians shared with me how to do that after I've mobilized the joint. I understand the grades of mobilization, and I knew which one I needed to do for that PIVM that I found out that was a problem. Even PTAs, I identified that there was a lack of knee extension with a total knee or a post-surgical case. And I understand the low load, long duration method, so I'm going to apply that because we know that technique. But you can see here all of the things. We don't just choose treatments that seem to make sense with the diagnosis that was on the exam, on the script. We don't just do the same 5 exercises for low back pain because that's just what we do. We want to unearth findings, and we want to dig up that gold, and we want to target very precisely, maybe with 2 exercises, maybe with 3 exercises, maybe with 5 manual therapy techniques and 2 exercises, but whatever the case, it's all about filtering our skills into really crystallizing high quality, highly dense treatment sessions, because not only is this going to happen in your exams, but it should happen to some degree or another in every single follow-up, which is why I'm so thankful that the PTAs tuned in. Thank you for those that have listened to the end. But let's try this out, and any feedback you can give me would be much appreciated. Thank you guys for pursuing excellence.